Hello and welcome to the topic dermatitis in the module dermatology. By the end of this topic, you should be able to define dermatitis, explain the pathophysiology of dermatitis, outline the causes and classification of dermatitis, describe the clinical manifestations of dermatitis, outline the investigations done for dermatitis, discuss the principles of management, and discuss the complications and prognosis of dermatitis. Let's get started. Dermatitis is an inflammatory skin condition. In this topic, we will be exploring contact dermatitis and seborrheic dermatitis. Contact dermatitis is a type of delayed induced sensitivity resulting from cutaneous contact with a specific allergen to which the patient has already developed a specific sensitivity, while seborrheic dermatitis is a papulosquamous disorder patterned on the sebum-rich areas such as the scalp, face and trunk. Physiologically, the epithelium forms a barrier to protect itself from environmental insults and allergens. It provides a tissue interface balancing the communication between the internal and external environments. In contact dermatitis, there are mutations in the gene encoding filaggrin, which is a key epidermal barrier protein. Filaggrin defects will cause release of epithelial cell-derived cytokines including TSLP, interleukin-25 and interleukin-33, leading to inflammation. Small organic molecules that are chemically reactive, also known as chemical sensitizers, will bind with self-proteins to generate immunogenic neoantigens through a process termed haptenization. Haptens or haptenated self-proteins are recognized by innate immune mechanisms in the skin, and this leads to the elaboration of a number of pro-inflammatory mediators, including interleukin-1 beta. As a result, skin-resident dendritic cells become activated. Hapten-induced inflammation recruits activated effector T cells back to the initial site of antigen encounter in the skin. The effector T cells release pro-inflammatory cytokines such as interferon gamma and promote the killing of haptenated cells, resulting in development of the classic inflammatory rash seen in allergic contact dermatitis. In individuals with seborrheic dermatitis, it was found that there are normal levels of malassezia but an abnormal immune response. Helper T cells, phytohemagglutinin and concanavalin stimulation and antibody titers are found to be depressed too. The contribution of Malassezia species to seborrheic dermatitis may come from its lipase activity, which causes release of inflammatory free fatty acids, and from its ability to activate the alternative complement pathway. There are multiple causes of dermatitis. For contact dermatitis, common allergens include poison ivy, nickel, rubber gloves, hair dye, temporary tattoos, textiles, preservatives, fragrances, drugs such as corticosteroids and neomycin, and sunscreens. Exact etiology of seborrheic dermatitis is unclear. Malassezia organisms are probably not the cause but are a cofactor linked to a T-cell depression, increased sebum levels, and an activation of the alternative complement pathway. It can also be a result of skin barrier dysfunction. Many drugs have found to be associated with seborrheic dermatitis such as chlorpromazine, cimetidine, fluorouracil, haloperidol, and lithium. So now let's take a look at types of eczema, which includes atopic dermatitis, which has been discussed in detail in the topic eczema, contact dermatitis, which is further classified into allergic contact, irritant contact, and photocontact dermatitis. Seborrheic dermatitis, also known as dandruff, dyshydrotic dermatitis, which commonly affects the hands and feet, nummular dermatitis as the skin lesions are coin-shaped, neurodermatitis where chronic itching and scaling occurs, and stasis dermatitis as the result of static veins. For both contact and seborrheic dermatitis, it is manifested with burning, scaling, and itching of the skin, while contact dermatitis occurs following exposure to allergens, irritants, or sunlight. Seborrheic dermatitis usually flare up during winter and early spring. For allergic contact dermatitis, patients complain of skin changes such as burning and swelling, especially in the eyes, face, or groin areas. Blisters and cracks occur in irritant contact dermatitis due to extreme dryness. The skin may feel stiff or tight, and there might be ulcerations. With examination, contact dermatitis usually involves hands or topical medication sites. Erythema multiforme may form, and it is a severe cutaneous reaction with targeted lesions. If there are intramural metal contact allergy, mucositis that mimics lichen planus may appear. Vesicles are found residing on red and swollen skin. Oozing occurs if vesicles has erupted, after which it will form a crust when it is dried up. In allergic contact dermatitis, the skin is commonly dry, scaly, and flaky. Additionally, the skin might appear to be darkened or leathery. Open sores are found in irritant contact dermatitis. For seborrheic dermatitis, its distribution follows the oily and hair-bearing areas of the head and neck, such as the scalp, the forehead, the eyebrows, the lash line, the nasolabial folds, the beard, and the post-auricular skin. The scalp lesion varies from mild, patchy scaling to widespread, thick adherent crust, and it can spread onto the forehead, posterior part of the neck, and post-auricular skin. The skin appears to be briny or greasy, scaling over red, inflamed skin. Hypopigmentation is seen in dark-skinned individuals, and in the trunk, there might be annular or geographic petaloid scaling. The major difference between contact dermatitis and seborrheic dermatitis is the location of the skin lesions. For contact dermatitis, it occurs at areas that come in contact with the allergens, while for seborrheic dermatitis, it is found at oily and hair-bearing areas of the head and neck. Potassium hydroxide preparation or fungal culture can be done to exclude tinea. Patch testing is done to identify specific allergens. Repeat open application test is reserved for those with weak or positive reactions to a chemical. It is used to determine whether the reaction is significant. The suspected allergens will be applied twice a day for a week to the side of the neck or behind an ear, and if clinical dermatitis does not develop, the reaction likely was not meaningful. Ultimately, skin biopsy is an option to help exclude other disorders, particularly tinea, psoriasis, and cutaneous lymphoma. The histology will show inflammatory infiltrate in the dermis, predominantly containing lymphocytes and other mononuclear cells. Epidermal edema such as spongiosis and microvesicle formation may be seen. Lastly, hyperkeratosis and parakeratosis may be seen in the epidermis and stratum corneum. Contact dermatitis is managed by identifying and removing the potential causal agents, while for seborrheic dermatitis, it is focused on early treatment of flares. Medical treatment are focused on suppressing inflammation. Topical corticosteroids are used for severe allergic contact dermatitis of the hands. 3-week courses of class 1 topical corticosteroids are required, while class 6 or class 7 topical corticosteroids typically are used for allergic contact dermatitis of intratriginous areas of the face. For seborrheic dermatitis of the face, use low-potency topical corticosteroids such as hydrocortisone, desonide, and mometasone. Systemic corticosteroid is of 2 weeks course of acute severe allergic contact dermatitis such as from poison ivy. Adults require an initial dose of 40 to 60 milligrams of oral corticosteroids, which is then tapered over a 2-week period. Sedating oral antihistamines may help diminish pruritus. Antifungal is a treatment option for seborrheic dermatitis. First-line therapies include topical ketoconazole, cyclopyrox creams, and gels. Systemic fluconazole may be helpful if seborrheic dermatitis is severe or unresponsive. When it comes to non-medical therapy, it aims to reduce flares of dermatitis. Patients are encouraged to have topical soaks with cool tap water with the addition of baro solution. Cool compression with saline or aluminum acetate solution reduce the symptoms of dermatitis. Emollients such as white petroleum may be beneficial in chronic cases. And specifically for seborrheic dermatitis, dandruff responds to more frequent shampooing or a longer period of lathering. Use of hairspray or hair pomades should be stopped. Shampoos containing salicylic acid, tar, selenium, sulfur, or zinc are effective and may be used in an alternating schedule. Acute complications of contact and seborrheic dermatitis are skin infections. In long term, there might be lichenification and hyper or hypopigmentation of the skin. Hair follicles on the scalp might be damaged in seborrheic dermatitis, leading to temporary hair loss. Dermatitis runs a better course if triggers are identified. Contact dermatitis usually runs a persistent or relapsing course, particularly if the material to which they are allergic to is not identified or if they continue to practice skincare that is no longer appropriate. Treatment of seborrheic dermatitis almost always results in an excellent response. It is unlikely to result in any durable, permanent resolution of the disease. So let's summarize. Dermatitis is an inflammatory skin condition. Contact dermatitis is a result of mutations of the gene encoding filaggrin, which is a key epidermal barrier protein. Mutation of it leads to defect in epithelial barriers and cause release of epithelial cell-derived cytokines leading to inflammation. Seborrheic dermatitis, exact etiology is unknown, but is most likely due to an abnormal immune response to normal levels of malassezia. Contact dermatitis is further classified into allergic, irritant, and photocontact. Dermatitis is diagnosed clinically, however, lab investigations might be required to rule out other causes and underlying conditions. Contact dermatitis is managed by identification and removal of potential allergens. Early treatment of flares is the principles of management for seborrheic dermatitis. We have come to the end of this topic. Thank you.